Very good morning to all of you. Today my topic is cyst of JAWS. Cyst is a pathological cavity having fluid, semi-fluid and or gaseous contents which is not created by accumulation of pus, often but not always lined by an epithelium. The origin of the term cyst means kyst, which means bladder. There are two main types of cyst, true cyst and pseudocyst. Now let's see the parts of the cyst. It has a lumen, which is an empty cavity which could be filled with fluid, semi-fluid or gaseous content. It's lining of the cyst. Next is the lining of the cyst, which is comprises of either epithelium or without epithelium. The epithelial component or the lumen is supported by a cystic capsule. A cystic capsule or wall. Its components are connective tissue, collagen bundles, blood vessels, nerves, muscles, and inflammatory cells, etc. These are the histopathological pictures of the true cyst. A true cyst is a cyst with an epithelial lining. It means that it has a lining epithelium surrounding the lumen of the cyst. Whereas in case of a pseudocyst, there is no epithelial lining. A pseudocyst is also called as a cavity or a false cyst. Based on this, the cyst has been classified into epithelial, which comprises of odentogenic cyst and non-odentogenic cyst. Under odentogenic cyst, we have a developmental cyst. In case of developmental cyst, the origin of the cyst is unknown, whereas inflammatory cysts are those cysts which has the epithelium is stimulated by the inflammatory stimulus. And we have non-epithelial cyst. Let's see WHO 1992 classification. Based on WHO 1992 classification, the cyst of JAWS has been classified as epithelial lined cyst, and it has developmental origin and odentogenic cyst. Under odentogenic cyst, there are 9 cysts: gingival cyst of infant, gingival cyst of adult, Odentogenic Keratosis, dentigerous cyst, eruption cyst, lateral periodontal cyst, botryoid odentogenic cyst, glandular odentogenic cyst, and calcifying odentogenic cyst. In non-odontogenic cyst, we have nasopalatine, nasolabial, mid-palatine cyst of infants, median palatine, median alveolar, median mandibular cyst, and globulomaxillary cyst. The inflammatory origin cyst comprises of radicular, apical, lateral cyst, residual cyst, paradental cyst, and juvenile paradental cyst, and inflammatory collateral cyst. In non-epithelial line cyst, we have solitary bone cyst and aneurysmal bone cyst. Cyst associated with maxillary antrum, we have benign mucosal cyst of maxillary antrum, post-operative maxillary cyst. In class 3, we have cyst of soft tissues of mouth, face, and neck, and it comprises of dermoid, epidermoid cyst, lymphoepithelial cyst, thyroglossal duct cyst, anterior median lingual cyst, oral cyst with gastric or intestinal epithelium, cystic hygroma, nasopharyngeal cyst, thymic cyst, cyst of salivary glands, and parasitic cyst. The latest WHO classification has many variations. Many cysts has been removed from the classification. In that odentogenic cyst, we have dentigerous cyst, and eruption cyst as a variant of dentigerous cyst. Next is Odentogenic Keratosis, lateral periodontal cyst with botryoid odentogenic cyst as a variant. Gingival cyst comprises of both the gingival cyst of adult, gingival cyst of newborn, glandular odentogenic cyst, calcifying odentogenic cyst, and a new variant that is orthokeratinized odentogenic cyst. Under inflammatory, there are only two cysts, but which comprises of radicular cyst. Under radicular cyst, we have residual cyst and lateral radicular cyst as variant. Collateral inflammatory cyst comprises of two, that is paratendous cyst and buccal bifurcation cyst. The non-odontogenic cyst comprises of only one, that is nasopalatine duct cyst, and non-epithelial cyst comprises of traumatic bone cyst and aneurysmal bone cyst. Now let's see the pathogenesis of a true cyst. There are three phases for pathogenesis of cyst. Phase 1, phase of initiation, phase of cyst formation, and phase of enlargement. For the phase of initiation in a true cyst is by proliferation of epithelium or epithelial remnant. Stimulus is by known or unknown etiology. Usually a known etiology is the inflammatory stimulus, whereas unknown etiology cysts are grouped under developmental cyst. This is a classification given by Schaefer based on the etiology and tissue origin. Based on that, we have cysts derived from rest of molasses, which comprises of radicular and residual. Cysts derived from reduced enamel epithelium, which comprises of dentigerous cyst and eruption cyst. Cysts derived from dental lamina, which comprises of Ordendogenic Keratosis, gingival cyst of newborn, gingival cyst of adult, lateral periodontal cyst, and glandular Ordendogenic cyst. There are certain cysts which are unclassified, which include paradental and calcifying Ordendogenic cyst. The cyst of developmental origin, which means that etiology is unknown, whereas in case of cyst of inflammatory, it means that these cysts are developing from inflammatory origin. Phase of cyst formation. There are two main concepts for phase of cyst formation. Based on Summers in 94, epithelium proliferates and covers this connective tissue surface of an abscess or a cavity is as a result of connective tissue breakdown by proteolytic or enzymatic activity. This concept is not accepted now. The most accepted concept comprises of the cyst cavity forms within the proliferative epithelial mass by degeneration, death of the cells in the center. The intracellular edema in the proliferative epithelial population, which causes accumulation of fluid which coalesce to form microcysts. Due to increase in the acid phosphatase activity in the central cells and weak proteolytic activity, causes autolysis of central cells. So as the central cells die off, it causes microcystic formation. Many more microcysts coalesce to form a large cyst. Growth and enlargement of cysts can be of different reasons. First one could be the osmosis and osmotic pressure. Usually, as the fluid accumulates in the lumen of the cyst, there is an increased hydrostatic pressure which causes expansion of the cyst. Usually, the mean osmolarity of the cystic fluid is higher than that of the serum. This is one of the reasons for the expansion of cyst. Another one by bone resorption and degradation of adjacent connective tissue, mainly because of prostaglandins and collagenase secreted by the cyst. Third one reason is the unremitting epithelial proliferation, which causes enlargement of the cystic cavity. Let's see what is a dentigerous cyst. It is also called as follicular cyst. It is defined as an odentogenic cyst that surrounds the crown of an impacted tooth caused by fluid accumulation between reduced enamel and enamel epithelium and enamel surface, resulting in a cyst in which the crown is located within the lumen. 20% of all, it comprises of 20% of all jaw cysts, and 10% of impacted teeth have dentigerous cyst. Usually, this kind of a cyst is seen in involving the permanent teeth. As you can see here, this is the crown surface and this is the reduced enamel epithelium, and the fluid fill happens between the space, and this space can also be called as follicular space. Clinical feature. Clinical feature, it is always associated with impacted teeth or a complex odontoma or a supernumerary teeth. The mandible and maxillary third molar region is the most common site, followed by maxillary cuspid. Second, it is usually seen in second and third decade of life. Male predilection, and with male predilection of 3:2. Usually these cysts are solitary lesions, but bilateral and multiple lesions can be seen in case of syndrome. An example is cleidocranial dysplasia and Merote Lamai syndrome. These cysts has the lining of the cyst is pluripotential, so it has to be meant to be an aggressive lesion. There can be facial asymmetry, teeth displacement, and severe root resorption. The expansion of bone can cause hollowing out of bone, and usually no pain is felt unless infected. Radiographic feature, what we can see is a radiolucent area surrounding the neck of the crown, which could be symmetrical. Like I said, the normal follicular space is 3 to 4 millimeter, whereas in case of dentigerous cyst, as the cyst grows, it grows beyond 5 millimeter. There are 3 radiographic patterns. First one is central variant, second one is lateral variant, and third one is circumferential variant. The central variant, this is surrounding an impacted tooth, and as the cyst grows, there is a chance that the impacted tooth being shifted or pushed or displaced to the lower border of the mandible. And in case of maxillary impacted tooth, there is a chance that it can be pushed into the maxillary antrum. The lateral cyst is lateral variant is usually seen in case of an partially erupted tooth, where the cyst is pushed into the lateral aspect of the crown. And circumferential variant, the cyst will be enveloping the entire tooth, but remember that the cyst is attached to the neck of the tooth. This image you can see, this is a central variant, and this one is a lateral variant. You can see the radiolucency is shifting towards the lateral side. This one is meant to be a circumferential variant. Histological feature, we have a cystic cavity lined by 2 to 4 layers of non-keratinized stratified squamous epithelium resembling reduced enamel epithelium. There is absence of retail ridges, and the connective tissue is thicker, and you can see that the connective tissue interface between the connective tissue and the epithelium is flat, and we have very loose fibrous connective tissue matrix, and due to pluripotential nature of the epithelial lining, we might be able to see mucus cells and respiratory epithelium also. Potential complications. The cyst is pluripotential, so there can be complications. One could be the ameloblastoma from the cystic lining or odontogenic crest. It can give rise to, and usually it is arising from in the form of a unicystic ameloblastoma. So how to differentiate between a dentigerous cyst and a unicystic ameloblastoma is based on the Wicker-Kronig criteria. Second one, keratin metaplasia in case of a long-standing cyst can cause squamous cell carcinoma. Third one, the mucus metaplasia also in the long-standing cyst can lead to mucoepidermoid carcinoma. The treatment of these kind of cysts is cystic enucleation. Eruption cyst. Eruption cyst is considered to be a variant of dentigerous cyst. It is a soft tissue variant of dentigerous cyst. It is an odontogenic cyst with similar histopathological features of dentigerous cyst that surround the tooth crown and that has erupted through the bone but not soft tissues, and it's clinically visible as a soft fluctuant mass on the alveolar ridge. The pathogenesis is similar to that of a dentigerous cyst. Here, the cystic fluid accumulates between reduced enamel epithelium and crown surface, but the cyst has already erupted into the erupted through the bone, and only we can see is a fluctuant mass on the alveolar ridge. Clinical feature, usually it is seen in children of different age group. It can be seen both in deciduous and permanent dentition, whereas in case of deciduous, in case of a dentigerous cyst, it is usually if you find it in permanent dentition. And the most common site is anterior to the permanent molars, and so anterior teeth. Here you can see a fluctuant mass or a nodular mass in an unerupted teeth. So fluctuant, translucent soft tissue swelling on the alveolar ridge can be seen here. If the presence of if there is a presence of blood, it causes a bluish hue to the cyst, and hence we use the term eruption hematoma. Histological feature is similar to that of a dentigerous cyst with the presence of an overlying oral epithelium. Inflammatory infiltrate is common, and dense cellular collagen capsule can be seen. The usual treatment for there is no need of a usual treatment for eruption cyst, because as the tooth erupts, the cyst may rupture. Sometimes if the cyst is obstructing the eruption of the teeth, then the cyst can be removed, surgically removed, so that which allow the eruption of the teeth. Next is Odentogenic Keratosis. The Odentogenic Keratosis is first described by the Philipson, and Pinborg and Hansen described its characteristic feature. Why it is called as an odontogenic keratosis? Because of the lining epithelium produce keratin and fills into the lumen and derived from the odontogenic epithelium. The Toller, based on Toller, it regarded it as a benign neoplasm, which is based on the aggressive behavior and also associated with nevoid basal cell carcinoma syndrome. In 2005, it was accepted as a tumor, which was grouped under neoplasm, and it was also associated with patch gene mutation. Let's see what is a patch gene mutation. Patched gene encodes for PTCH protein. It is a tumor suppressor gene. It is a member of sonic hedgehog signaling pathway. Sonic hedgehog signaling pathway that provides information for the embryonic cells of the proper cell proliferation and differentiation, and it has a role in embryogenesis, metamorphosis of different species. So in adult life, the mutation can cause us tumorigenesis. So within the sonic hedgehog pathway, we have patch, SMO, and SHH proteins. Patch gene is a tumor suppressor gene, SMO is a oncogene, and SSH gene. So during an inactive SSH pathway, the patch gene will be bound with SMO gene. So this stops cell division. Whereas in active SSH pathway, SSH and patch gene will be combined, which allow the free SMO to oncogene to be activated, which helps in cell division and differentiation. This happens in the tumorigenesis also. Whenever the patch gene and SMO gene is mutated, the fusion occurs. The activity, the PAD gene activity is lost, whereas in case of SMO gene, it gains a mutative power, or its activity is exaggerated here. So in case of a tumorigenesis, SSH gene combines with PAD gene, which causes pre-SMO, which lead to tumorigenesis. The reason why Odentogenic keratosis was grouped under a tumor in 2005, that based on its local destructive and aggressive behavior is its histological feature, that is basal cell budding and proliferation and increased mitotic activity in the suprabasal layer. Another one is the genetic reasons to involvement of PAD gene mutation. PAD gene mutation was seen in both sporadic and syndromic cases, and loss of heterozygosity type of mutations were also seen, and its association between nevoid basal cell carcinoma syndrome. But in 2017, WHO again classified it into cyst category. These are the reasons: mutations were less in non-syndromic cases, and also absence of PTCH and SMO gene mutations in few sporadic cases. PTCH mutations can be seen in other cysts like dentigerous and orthokeratinizing cyst also. So it is not only confined to the tumor. PTCH mutation is also seen in other cystic category. The term tumor cannot be used for a lesion that has morphological appearance of a cyst. And next one, the resolution of OKC was seen in decompression, the technique that relieves the pressure within the cyst that causes it to grow. Origin of Odentogenic keratosis. It originates from dental lamina remnants and basal cell hamartia and tooth bud. If the cyst arises from tooth bud, it forms the replacemental variety of the cyst. Clinical feature, usually a central OKC, which is most commonly seen, is arise in second to third decade of life. There will be slight male prediction. You can see a mild swelling in the mandibular ramus region or in the third molar area. Multiple OKCs associated with nevoid basal cell carcinoma syndrome. Mostly it is asymptomatic because it has an anteroposterior expansion, and few may have pain and swelling and first discharging if secondly infected. Peripheral OKC can be seen in gingiva and cheek region, etc. Radiographically, we have unilocular lesion with well-defined peripheral rim and scalloping border. The multilocular cyst, the central cavity may be presented with satellite cyst or large cyst, mostly show an anteroposterior mode of expansion without much involvement of cortical plate. Hence, enlargement is not evident. In severe cases, it involves the entire mandible or maxilla, may involve the maxillary antrum, destroying the floor of the orbit and cause proptosis. It can even displace the inferior alveolar nerve, and limited root resorption is seen in case of OKC compared to that of a dentigerous cyst. We'll see different types: envelopmental, replacemental, extraneous, and collateral. Follicular OKC if the tooth erupts into a pre-existing OKC. This figure shows the anteroposterior expansion and scalloping border. You can see that the cyst is going between the roots of the teeth, and it seldom resorbs the root of the teeth. It has an anteroposterior expansion and a scalloping border. This particular image radiograph shows the scalloping border of the cyst. It has it's very extensive. It has extended into the ramus and condylar bone and cornoid bone. to the midline of the jaw. Based on variants, replacemental variant, when the cyst replaces the tooth germ, instead of tooth germ, we have the cyst in its position. So this reduces a tooth number, a tooth from the jaw line. Next one is envelopmental variant. In case of envelopmental variant, the cyst envelops the impacted teeth. Extraneous, if the cyst is away from the jaw, tooth-bearing areas of the jaw, and most commonly it is seen in the ramus of the mandible. Collateral, when the cyst is close to the roots of the teeth. Follicular Okc, as the name suggests, the tooth erupts into the pre-existing OKC, and here the histological pattern is that the upper part of the cystic lining we have the feature of OKC, whereas lower portion where it is attached to the tooth shows the feature of a dentigerous cyst, hence the name follicular Okc. This is a gross specimen. Characteristic feature of lining epithelium. It is lined by parakeratinoid stratified squamous epithelium, which shows corrugations and infolding. The lining is uniform, which is 6 to 8 cell layer thickness, and it has a prominent columnar palisading nucleus and polarized basal layer, which gives a picket fence or tombstone appearance. So basal cells show palisaded nuclei and reversal of polarity, and the basal cells thereby look like uniform tombstone arrangement or a picket fence arrangement. Other features include 83% of cyst comprises of parakeratinoid stratified squamous epithelium. The 10% of OKC comprises of orthokeratinoid, which was later grouped as a separate entity in 2017 classification. Now it doesn't have any rete ridges, and epithelium shows separation from the underlying connective tissue. This is considered to be one of the reasons for high recurrence rate. The mitotic activity is more. The capsule shows islands of epithelium, mainly satellite or daughter cyst. Satellite or daughter cyst are seen mainly because of the infolding of epithelium into the underlying capsule. So in a cross section, they appear to be like smaller cysts in the connective tissue. The lumen is filled with straw-colored fluid or thicker creamy material. The creamy material is mainly keratin, and there is protein is low soluble than that of the patient's serum. The lining rarely shows a dysplastic transformation. Among the linings, that is parakeratin, orthokeratin, parakeratinized epithelium has higher recurrence rate. There is a term called as pigmented OKC. Pigmented OKC comprises of melanocytes. You can see infolding of epithelium into the underlying connective tissue. You can see here the epithelium, there is absence of rete ridges, so epithelium tend to peel off from the underlying connective tissue capsule. These are the daughter cysts. And small islands can be seen. Ordendogenic epithelial islands also can be seen here. The conventional treatment methods included marsupialization and enucleation and primary closure. enucleation and packing opening, but this caused rather recurrences in case of OKC. So OKC has 13 to 60% of chance of recurrences, mainly because of presence of additional remnant of dental lamina, fragmentation of epithelial lining, and association of nevoid basal cell carcinoma syndrome. So the preferred treatment for OKC is enucleation with peripheral osteotomy and block osseous resection in case of larger lesion, enucleation with carnoid solution or liquid nitrogen cryotherapy, and excision of overlying attached mucosa to prevent basal cell hamartias. This concludes the class. Thank you.